Roberta, it is an absolute pleasure having you on the podcast today. We've had plenty of good talks behind the camera, and one of our missions of this podcast of Return on Health is to bring the important conversations that happen, in private, bringing them to the public. And so we got to meet in 2024 during the Healthy Longevity Talent Incubator at the Academy for Healthy Longevity in Singapore. And we saw each other again in 2025 at the Healthy Longevity Talent Incubator last year in a different role, mentoring what was happening there in terms of the city missions and research. So I'm super excited to bring you on the show today. You're a geriatrician, you're a geroscientist with a PhD on cognitive frailty. And I think you have a very interesting career trajectory. Maybe you walk us through why you did what you did in your career and why the things that geriatricians see day to day actually matter for the whole longevity debate that is currently going on.
Thank you, Miguel and Nico, for the invitation. I'm so thrilled to be here to speak about something that I'm so passionate about, which is aging. So, as you rightly so said, I am a geriatrician and I'm also a geroscientist. So, this gives me a unique, powerful perspective on aging and health span. It allows me to see aging from two different perspectives, but which are complementary. And so, as a geroscientist, I study the biological mechanisms of aging. So, I see the upstream drivers of aging. And so, I see what's happening at the cellular and molecular level. And then, from the point of view of a geriatrician, I see the real life consequences of those processes in my patients. So, every day when I care for older adults, I look at problems which are not diseases like just cardiovascular disease or diabetes. I look at system diseases, and these manifest as, for example, lack of mobility. Maybe they manifest as falls. Maybe they manifest as incontinence or weight loss. So, as a geriatrician, I have been trained to look at systems rather than organs in silos, which is an advantage to other medical specialties. Because if you go to the orthopedic surgeon with your frozen shoulder, he is not going to look anywhere else except at your shoulder. Whereas if you go to the geriatrician, they're not only going to look at all your body systems, but in addition, they're going to see what your environment is like. How is that environment helping you or hindering you? How is your family or your social network supporting you or hindering you? So, in this respect, I feel privileged that I can look after older adults from a holistic point of view. So, these two perspectives are like marriage, you get to see something, what's happening at the cellular, molecular level, but also at the clinical aspect.
Yeah, sounds like pretty much a match made in heaven. And
Right,
I
right.
think like one of the most important things in your discipline is probably frailty. And I know that you're really passionate about frailty as well. And I researched it a bit as well and found that frailty has a sort of clinical definition, the Fried phenotype, 5 criteria. But I think like most people out there have no idea what it means or how it's measurable, if it's measurable. So can you just walk us through that? What is frailty really like in plain terms?
So if I had to find another single word for frailty, I would say vulnerability. And maybe when you mention frailty, people would have the image of an older person, stooped, maybe cachectic, walking slowly. That is the extreme end of frailty, but it can also be subclinical, whereby you wouldn't really see it with your naked eye, but if you test for it, you would find it. And what happens is that our systems, our musculoskeletal system, our heart, our lungs, our ovaries, everything has a reserve. Our brain, they have reserves. And then when we are young, we have a lot of reserves. So when we encounter stresses, this could be an infection, could be we've started a new drug, could be that it's a psychological problem, someone in our family has passed on. Usually we have enough reserves to overcome that threat and recover spontaneously to our previous level of function. What happens in people with frailty? Their cognitive reserves have gone below a certain threshold. So when they encounter a stress, even simple, like as I said, like a urinary tract infection, which is very common in the older adults, they would take a long time to recover, and maybe they won't even recover to their previous level of function. So next time when they're going to start and another infection is coming on, they have started from a lower baseline, and so on and so forth, until at one point in time, they have reached that threshold and they are frail. And then disability sets in, and then they're dependent, they're more likely to be hospitalized, more likely to go to an institution or die early. So frailty has a lot of consequences. As you rightly so mentioned, you mentioned the frailty phenotype, which is based on 5 criteria, which is unintentional weight loss, grip strength, exhaustion or fatigue, which is based on 2 questions from a depression scale, and lack of physical activity. And what happens is that if you have 3 out of 5, then you are going to be frail. If you have 1 or 2 of those items, you are going to be pre-frail. If you have 0, you are still robust. But nonetheless, although this is based on the frailty phenotype, only physical domains, there are several other frailty assessment tools. In fact, when I was doing my PhD, one of my papers was researching how many frailty assessment tools there are, and there were hundreds of them. So it's very difficult to have something which is standardized. The frailty phenotype is easy to do in a clinical setting in a way, but nonetheless, it doesn't take into consideration cognitive assessment. So that is also the drawback of using the frailty phenotype. What is good about frailty is that previously, for example, if you were due for an operation, they would say no because you are 80 years old. Nowadays, they say, what is your frailty status? Because that gives us a better indication of your cognitive reserves, how likely you are to recover after that operation. So also when, for example, there was the COVID infection, where are we going to allocate resources? Resources are limited. You cannot just allocate resources according to age. You have to allocate resources according to your reserves. And if you think about it, if you take 2 20-year-olds, they're probably, from a health point of view, they're going to be the same. If you take 2 80-year-olds, they're going to be completely different. One can be still playing golf and the other one is in a nursing home. So that's how much frailty is important and why I got so attracted to frailty in the first hand.
Yeah, that makes a lot of sense. And already a lot of things I didn't know, which are extremely interesting, to be honest. And you already mentioned that there are countless ways to sort of measure frailty. Like, is there, you already mentioned that there isn't really a standardized measurement yet, but what are, like, in your clinical opinion, what's the best way to measure frailty early?
So I think there are, the frailty phenotype, there are criteria. So for example, how much weight loss you have lost, unintentional weight loss. So there are criteria and for example, criteria for grip strength. If you are in the lowest quintile, then you are frail. So there are benchmarks for this. But nonetheless, in different settings, the other option is to look at an assessment tool based on health deficits, how many health deficits you have. And that might also be easy because you just look at the medical records and say, do you have heart disease? Yes or no? Do you have eye problems? Yes or no? So then you don't need to measure anything. These are the two different ways of doing it.
Interesting. And so, as a geriatrician, taking care of older people, you kind of see them at the later stages of their life and also kind of at the end of the preventable window, or what we may then call tertiary prevention. When do you see what you see in clinical practice? Do you think, what's your thought? Is it like, I wish I had seen that person 30 years ago to kind of having had a chance to change their trajectory, because now it's maybe only about damage control? What are your thoughts when you're dealing with these patients?
Yes, you're absolutely right. It's quite frustrating when you are seeing older adults with already established and advanced diseases, and you say that if I have seen that individual when they were 30 years old, I would have told them to exercise, for example, or to eat a good balanced nutrition, because then they wouldn't have, or maybe they would have their disease a bit later in terms of, for example, dementia, Alzheimer disease. We know that this is 45% of all dementias are preventable. Imagine that. And nonetheless, it's still a very massive problem. And we know that almost half could be prevented if, when these individuals were younger, they were given the right advice. Also, for example, if you see these older ladies coming into the clinic after a fracture, a fall and a fracture of their hip, if when they were younger, they would have been advised to have proper nutrition, exercise, maybe hormone replacement therapy, they wouldn't be where they are now. Also, if you think of other things like urinary tract infections, you get older ladies with recurrent urinary tract infections, lots of antibiotics. This would disturb their gut microbiome. Because of that, they would be in delirium. Then, if they were younger and they were prescribed vaginal estrogens, they would probably not have ended up where they are now. So many things that if we start investing in our health when we are in our 30s, we don't take our health for granted like we do with our finances. We start investing when we are younger. We don't wait until we reach our pension to invest. Similarly with health, the more you invest, the more you're going to have reserves. So when you start moving down, you take longer to reach the frailty threshold that we referred to earlier. So
Yeah,
it is frustrating. It is frustrating to see older people in this setting, and being robbed of their personality, being dependent on their basic activities of daily living. They have worked hard. They have they've had so many experiences, and now because of their ill health, they cannot enjoy the wealth that they have generated. They cannot spend time with their family. They cannot pass on their skills to someone else. So the repercussions are extensive, and it breaks my heart to see this.
I totally agree with you. I think, this is so important, and it's important for two sides. I think it's important for the people, potential patients, so that they know that they actually have lots of agency over their own health if they are proactive with it, because there's so many modifiable risk factors that they can influence. But then on the other side, also on the provider side, because unfortunately, I've also seen firsthand with my grandmother that, you know, they do not use, if not specifically asked and pressured for it, to use all of the testing they could be using in order to kind of see where current risk factors are, whether it be osteoporosis or whatever it may be, that then also, and nutritional status that might have an impact on that, and whatever it may be, that kind of also influences the risk of something such as falls and fractures, which end up having a very high mortality rate after a year after the operation, right? And so I think it's really great that you're spreading the word, and I hope we can reach both people, who have maybe family members they can send this to, and to kind of that people are more proactive with their health, but also that providers should be making use of all the tools that we have established in research that we can use. But to try and be more on the encouraging side of things, what have you seen in practice in terms of if someone is already, kind of pre-frail or in decline, if we intervene then, maybe not a 30-year-old, but maybe someone who's already, in their 60s, 70s and already showing first signs. What are our options there, and can we actually change the trajectory?
Yes, it is possible to change the trajectory, especially if you are still in the pre-frail stage. And if you are in the robust stage, it's also good because you still need to make sure that you try to top up
Mm,
the capacity of your of your systems. So what I think is extremely important is the loss of muscle mass that occurs as we grow older. This starts so we peak in our 20 to 35-year-olds, and then after that, it's a decline. And in women, the decline is even faster around the menopause transition. So if you are now already 60 years old, studies data have shown that with the right resistance training, 3 sessions a week,
Mm.
and with the right nutrition, that you need to eat enough protein, around about 1.2 to 1.6 gram per kilo body weight, you are stimulating muscle protein synthesis. We know that it's more difficult as you grow older because of anabolic resistance to build muscle. You don't just accept that as fate. You need to do something. You need to be mindful that that is going to happen if you don't do anything. But on the other side, there is something that you can do. And this all depends on yourself. And we know that exercise not only improves muscle mass, and muscle is important not just to be able to move, but it's also important because it maintains insulin sensitivity. It maintains a robust metabolic health, but also because muscles, when you have bigger muscles and you are exercising, you are releasing elixirs into the brain. And these help to form new neurons and also to form new connections between neurons. So you are not just improving your physical capacity, but also your mental capacity. So if I see someone in their 60s, first and foremost, I would dive into this, into
Hmm.
trying to maintain and actually increase muscle mass.
Yeah. Yeah, that makes a lot of sense. And I think like this is a topic which not enough people understand, but at least I feel that more and more people nowadays, especially in my and Miguel's age, are getting into strength training because they know of the importance of it. But like, for example, my grandma or my grandpa, they never really trained properly in a gym or something like that because this was only for bodybuilders. But I think this notion around this changed, at least in our generation, which is amazing, but still not enough people know about this, unfortunately, especially in the older generation. So that's why it's such an important factor. What is also another extremely interesting topic, which I first heard from you actually, is the topic of peak span. I mean, in the world of longevity, most people talk about lifespan or health span and the differences between them, and also what really is longevity. Is longevity rather like health span extension, or is it lifespan extension? That's really an argument a lot of people have in the industry. But now there's another word or another concept which is called peak span, which I find to be extremely interesting. So can you walk us through that? What really is peak span? How does it differ to health span, for example?
Right. So, as you rightly so explained, initially it was all about lifespan and extending life. In the end, we realized that it's the quality of life that matters. And so we introduced health span. And health span is that period where you are without ill health. So we're still focusing on disease. We're still saying that it's that part of life where you don't have any diseases that are affecting your health. When we move to peak span, we are going a bit further because we are relying on function, on functional performance. It's when your system, so your system can be functioning at 100%, that's ideal. When they fall below the 90% peak performance, it means that you are drifting away from your peak and you're heading towards frailty at the very end of that spectrum. So we need to maintain our systems very close to their maximal potential. This is extremely important. This is still a concept, but when you think about the different organs in the body, it's important to understand that the different organs age and drift away from their peak span at different levels, at different rates. So if you think about two organs that really drift away from their peak span early, it's the thymus, which is important for the immune system, and the ovarian, the reproductive system, especially in women. We know that also it peaks at around 20, 25 years. And then by age, more or less the ages of 40, early 50, then you have the menopause transition. And that is when your ovaries are going to shut down. The consequences of this are tremendous. So I feel that the concept of peak span is wonderful because it triggers individuals as well as healthcare professionals to try to maintain organs at their peak function, not just not having disease. That is okay, but we're always striving for excellence to try to be as close as possible to the peak.
Yeah, that's very interesting. Also, the two organ systems you've mentioned, thymus and ovaries, that they're kind of the quickest one to decline and function. Recently there was some headlines on social media where famous biohacker Kayla Barnes Lenz posted her test results. I'm just gonna read the first part of the post, saying, "I'm officially the first woman in the world to have my ovarian biological age measured. Until now, ovarian aging, the primary driver of female biological aging, has not been clinically measurable. My ovarian biological age measured approximately 5 years younger than my chronological age. In the context of a reproductive lifespan that spans only around 40 years, around 5 years is substantial, especially this early." Then, as a disclaimer, this was done using an AI driven ovarian aging clock developed by Timeless Biotech. What's your comment on that?
I think this is really exciting to have a clock that measures specifically ovarian aging. Maybe this is still early years, but it is still something to keep in the pipeline for the future. It's important to know that if for your ovarian age is doing great, and usually the ovarian age is the one that declines, is one of the earliest that declines, as we described just now, then imagine that probably the other organs are also, you haven't tested the other organs, but most probably they're also working optimally. So this is an inference, but that's what's so interesting about this, not just knowing what's your ovarian age if you are a female, for fertility, for example, but also because this has influence on the other biological systems, your musculoskeletal health, your endocrine health, your digestive health. And therefore, it is something that it's exciting.
Yeah, it's very interesting because also in the context of ovarian aging, there recently has been a study that's also been going all over social media where it said that women that became mothers in their 40s, that they were more likely to reach 100 years. And of course, it's likely multifactorial. But one of the hypotheses was that just having the possibility, from a reproductive health point of view, to still give birth and still have like functioning ovaries at that age is actually like a really good predictor of, you know, a good lifespan and like many years spent in good health. Do you agree with that hypothesis?
I think it makes sense. It is logical because, as we have just said, the reproductive organs are the ones that switch off quite early. So that means if these organs are still in good function, so much so that you are so fertile that you can conceive, then that probably is because the other systems, the overall physiological systems are also working at their peak. So it's usually never one system is right and another system is wrong. It's usually one system. It's like a subway, you know. Then one thing affects the other. But if you have something that is usually almost dead by the age in your 40s and it's still good enough to conceive, then that's really gives a good impression of what the other systems are working like.
Yeah, yeah, that makes a lot of sense. What I'm wondering is, like, I mean, Kayla Barnes, for example, she's, I don't know, I think she's like in her mid-30s, and she's working quite hard on her entire body, obviously. But what I'm wondering is, like, for the normal person, not the hardcore biohacker, like, is there a sort of critical intervention window, like maybe around menopause, or something like that, where the trajectory can still be meaningfully changed? Like, what's the last point where you can actually do something to yeah, like, get a benefit out of this? Like, yeah, just
Yes, I think it's always good to know that there are some diagnostics, but also what are you going to do about it? You know, how could you improve that? Data has shown that if menopause hormone therapy or hormone replacement therapy is started around 10 years during the menopause transition or below the age of 60, then it's more likely to have positive effects on the cardiovascular health, on the musculoskeletal health, on the metabolic health, cognitive health as well. So I think it's very important here to mention that women who are even as young as their late 30s, 40s, and they're starting to see that, for example, they're having these vague symptoms. They're not who they used to be before. They think they're going crazy, but it's because they're having fluctuation of their hormones. Then, or maybe their menstrual cycles are also becoming irregular. There's a change in the flow. It's important to seek help from a menopause specialist, not just go to another doctor and say, okay, I go to this doctor, to the psychiatrist because I feel very depressed. Then that psychiatrist would give you antidepressants. And then you say, but now still cannot sleep or I still have palpitations. Then you go to another one and they give you a beta and you keep shopping around. I've seen it with my own eyes because I do run a clinic for specifically for women's health in midlife. And you see it, they come with a list of medications. And it's because no one has joined the dots. And it's a pity to see this because, first of all, their quality of life is miserable now. And they've spent a lot of money and a lot of time going from one healthcare professional to another. But the most important thing is that they're being deprived from starting hormone replacement therapy if it's appropriate for them to prevent future problems, to remain at their peak span. And so here I would like to emphasize how important it is to not think as ovarian failure as something that is simply annoying because you have a lot of symptoms, but it has so much consequences on future health. And this is something that I would really love to emphasize because it's not just for the individuals. The individuals go to the healthcare professionals. They think that the healthcare professional is the person who is going to help them and knows all the information. So they trust what they're advised to do. So they're doing their part. They're seeking medical help. But on the other hand, they're not being offered the proper advice. Maybe some healthcare professionals are still afraid to prescribe hormone replacement therapy. Maybe this could be even not just if we're talking about the primary care physician, but also sometimes gynecologists, So this is shocking. We need to really open our eyes. And as females, we need to educate ourselves and not just stop at the first no that we encounter. We need to be able to prepare ourselves for these consultations, go with questions and say, why are you not prescribing hormone for me? And not just hormones. This is part of the puzzle.
Mhm.
The healthcare professional should be able to advise you also on how is your sleep, how to optimize your sleep. How is your nutrition like? Is it supporting inflammation or is it anti-inflammatory? When it comes to physical activity, what kind of physical activity are you doing? Are you still running on the treadmill, trying to remain slim? Or are you trying to also include weight resistance? Are you still afraid that if you lift weights, you're going to become extremely muscular? I wish. I tried. Have
You're
you
not
ever,
going to become a pro bodybuilder after one gym session. We can tell people that.
I mean,
Yeah.
if you look around, how many bodybuilders do you see?
Yeah.
Very little, and a lot of lift weight. So you're not going to, unless you're really supplementing yourself with
Mhm.
exogenous hormones and so on, you are not likely to become an extreme bodybuilder and start, unless you really want to, I mean, there's no harm. And I have nothing against women who would like to participate in bodybuilding. So everybody to their own.
I love your message, honestly. I think it's so important that first of all, we should stop seeing things in isolation, especially from a provider's point of view, from specialist's point of view, and thinking that a person that presents with 3 symptoms has 3 different issues. I think it happens all the time, but and I'm going to say this, my personal opinion, I think it's mostly wrong because it's rather unlikely that a person has so many different issues at the same time rather than maybe 1 or 2 issues that go hand in hand that actually cause all of these things at once. And so I think we need to do better. I think it's important that people demand it, and so that the practitioners are also then kind of forced to keep up with the medical literature and actually offer the best quality services to their patients, because people have been historically completely outsourcing their own health to their doctors. Now it's changing a bit because people are more informed, and I think sometimes it needs to have this like bottom up revolution where if there's a demand for certain things, the other side, the supply side, then also really needs to cater to that demand. And so I love that view, and I think it's so important with regards to women's health, with regards to general health and prevention for age-related diseases, because so many of the things, and you've touched upon this before, are actually modifiable, right? And so also the things that people often are most scared about, something like neurodegenerative disease, dementia, Alzheimer's, 45% is actually known, what causes 45% of that risk. And I want to put that in here because I know that you're very passionate about this. Because when reading through the kind of 2024 Lancet Commission on Dementia, it's a review of stating these 14 risk factors, and they state how much percentage, how much each risk factor is contributing to that total dementia risk burden. And interestingly, it's not diabetes, smoking, or hypertension that's highest amongst that list, which would be a fairly reasonable guess, but it's actually hearing loss is at the very top. So, what does it have to do? Why is hearing loss such a big risk factor? And why should we all care more about our ears?
Yes, they are so, I mean, hearing loss is extremely common. If you think about it, it's 20% of the population worldwide suffer from hearing loss. And this is around 1.5 billion. And this is expected to increase to 2.5 billion by 2050. So in 25 years, we're going to have 1 billion people more, which is astounding. And then when you think about it, hearing loss, there are various degrees of hearing loss. Actually, 5% of the world population have disabling hearing loss. And when you have disabling hearing loss, then you would need to use rehabilitation techniques, hearing rehabilitation techniques, to help you live independently. And when you look at the global burden of diseases, if you look at the 50 to 69-year-olds, so these are not very old people, it ranks third in the list of the most common causes of disability. And when you look at the 70 plus, it skyrockets to the first place. So why are we not doing anything aggressively about it? Why are we just putting it under the carpet? Maybe because it is not sexy, to have hearing loss. But in the end, it is something that we need to identify and we need to treat so that there wouldn't be consequences. Consequences could be social isolation. In the end, social isolation also increases the risk for dementia. So while hearing loss is the greatest risk for dementia prevention, if we treat hearing loss, then we would reduce the risk of dementia by 7%. Social isolation reduces the risk by 5%. So target hearing loss, you might also target social isolation, because that's what happens when you have hearing problems. You don't want to go and engage in social activities because you just hear people talking, but you don't understand what they're saying. And so this is extremely important. So also something to understand is that although disabling hearing loss is, as I said, very common, 5%, it's also expected to increase to 10% by 2050, meaning 1 in 10 will have disabling hearing loss. It's crazy to hear this. But then the uptake of hearing aid, it's only 17 to 20% of those who have disabling hearing loss are using a hearing aid. Why is this? Because first of all, it can be that they are costly and they wouldn't be covered maybe by insurance. So this could be one problem. The other problem is stigma. They say, if I wear a hearing aid, it means that I'm old and I want to seem old. If you wear glasses, that's something fashionable, everybody is trending around with nice glasses. But hearing aids, no, that is not in fashion and we don't want to put it on. Especially males, because they have shorter hair and then it's more likely to show. So we have, a big issue. There is the issue that it is very common. It's causing a lot of disability and people don't want to use the hearing aid. Also, when it comes to cochlear implants, it's even less the uptake of cochlear implants. Some people think that this is some great brain surgery that you need to do, but actually, this is even being done on an outpatient basis. So, it's like a one-day thing. So nothing major. So, and you would say, how does that happen? No, how is the hearing and cognitive decline associated together? So one thing could be what is called the cognitive load. Because when you have hearing impairment, the sounds are muffled. And so the brain, to be able to decode that, it needs to recruit other cognitive domains. It's cognitive reserve to try to decode that stimulus. And in doing so, it affects other cognitive domains. So it's like you are recruiting your assets to decode that stimulus at the expense of cognitive domains, which are important for executive function, for example, to be able to complete complex tasks and memory. So in the end, in the beginning, this is something that can be rewired. The longer the hearing loss, this becomes something chronic. And this is something that we found in our study, in our butterfly study, where we studied 8-year-olds and older. They were community dwellers. And we saw those who have a hearing aid and those who don't have a hearing aid, how that affects cognition. And we found that in males that do not use a hearing aid, there was an association with cognitive impairment, but not in females. And it could be because usually hearing loss starts earlier in males, so the trajectory is much longer. And because of that, the neuroplasticity that occurs cater for the muffled sounds becomes chronic. So then we might have seen this change. So that could be one reason why hearing loss can give rise to cognitive impairment. Another reason could be that we have described now, that hearing loss often leads to loneliness, depression, and social isolation. And all of these together then also give risk to dementia because you are not stimulating the brain. So you don't have enough cognitive reserves. Some other interesting thing is that they may share a common pathology. Age-related hearing loss and cognitive decline may share common cardiovascular issues. So you have blood supply issues to the cochlea and blood supply issues to the brain. And this we have seen also in our study that, for example, our males had more, there was a statistically significant difference between males and females who did not use a hearing aid when it comes to ischemic heart disease, when it comes to smoking, and when it comes to alcohol use. So this could be one of the reasons why we saw it in males and not in females. One interesting thing is that it could be an overdiagnosis because cognitive tests are usually depend on hearing. If you do several tests, the MMSC, the MOCA test, you are first explaining the instruction in speaking. Sometimes you need to speak back. So although they could also read it, but sometimes because you have hearing loss, you tend to be like, you don't do your best. You're a little bit introvert, because you're scared because you have problems with your hearing. In our study, we try to overcome that by doing a reaction time test where you need to actually move your hand and react to light to assess processing speed and other things. These could be the reasons why hearing loss can be associated with cognitive decline. There have been studies to show, because you would say, okay, but are there any studies to show that if you use your hearing aid, then you would have an impact on cognitive impairment? So there has been one large randomized control trial called the Achieve trial. And the interesting thing is that they recruited people who had no cognitive impairment at baseline. They were 70 to 84 years old. And they recruited individuals from two sources. One was by advertisement, and the other one came from an ERIC study. And in that study, the individuals had more diabetes, more hypertension, less education, smoked more, they had lower baseline cognition, a little bit older. So they had more risk factors for dementia per se. And they sort of randomized individuals to either audiological counseling and a hearing aid or just like education over covering chronic diseases. And they measure and they follow them up for 3 years. And they did a comprehensive psychiatry battery to see if there was any improvement or not. What they found out is that there was a 48% reduction in the 3-year global cognitive decline compared with the control group, but only in those individuals that had a higher baseline risk for dementia, those that came from the ERIC group. So this is the only large randomized control trial because it's not ethical to actually tell people, okay, you have hearing loss and you get the hearing aid and you don't get the hearing aid. So it's quite difficult. But there were other observational studies, and these observational studies showed not 48% differences in risk, but between 17 and 19% lower risk of developing dementia and cognitive decline in the hearing aid users compared to the non-hearing aid users. So it seems like a hearing aid is cost saving for society because it would decrease the risk of dementia. And believe it or not, some people are afraid of cancers. They would do anything, but actually some people have recovered from cancers. I have never encountered anybody has recovered from dementia. So it's even more a burdensome disease, a really nasty disease that if we know that there are things that we could do, especially since we know that there's no treatment, disease modifying treatment, then we have to really focus our attention on preventing by looking at those risk factors. But then hearing loss is at the top, so why
Definitely.
not?
I think what I've heard from you now is that hearing loss pretty much is probably the most underrated longevity risk factor, just because it's not quote unquote sexy to talk about this. Because, yeah, as you said, people don't really want to wear a hearing aid, for example. People don't really want to talk about hearing loss at all. So, yeah, I think more and more people should get to know that this is really one of the most important factors for neurocognitive health and all of this. What I want to do now is we want to do a new segment, which is called Busting the Myths. So what I want to do now is play a game. So what I'm going to do is I'm going to say something that most people believe about aging. And I want you to tell me whether the evidence supports this or, let's say, demolishes it. So the first one would be cognitive decline is a natural, inevitable part of getting older.
So cognitive aging does exist. We know that when it comes to fluid cognition, like processing speed, like working memory, these things do slow down. Other things like crystallized cognition, whereby it is more verbal fluency, knowledge, these are things that actually improve. And then if they decline very slowly. So cognitive aging does occur, but it doesn't necessarily move to the part of cognitive decline. And one way how to improve your cognitive reserves is by moving, by learning, and by keeping socially engaged.
Interesting. Okay. Now, next myth. You can't build meaningful muscle after 60.
No, that's also a myth. And it is more difficult as because of anabolic resistance. It's more difficult to build muscle as you grow older, but with the right amount of protein, also making sure, as we said before, 1.2 to 1.6 grams per kilo of body weight, making sure that we are spreading that across our meals, focusing on leucine, which is an important amino acid for muscle protein synthesis, which you could find in eggs, chicken, lean beef, turkey, or in whey protein. And also doing resistance training. And you don't really need to be sleeping at the gym. If you do three sessions a week, but every time you are trying to lift heavier, then that's enough to stimulate the muscle and then support that with proper nutrition.
Yeah, definitely. That's so important. And I'm telling this to a lot of my friends for years now. So I hope they listen to you if they don't listen to me. The next one is that there's a growing movement to classify aging itself as a disease. For example, the WHO has added aging-related conditions to ICD-11. So what I'm wondering is, like, what's your view? Is aging itself a disease? And does the framing actually matter clinically?
I think aging is part of our physiology, but what's important is that now there is an FDA approved ICD code for aging associated decline in intrinsic capacity. And what I find interesting is that research now could use that as an endpoint rather than waiting for a disease to occur, which would usually take much longer. That's what I see is the advantage. And also so that physicians could actually say, listen, this treatment, I'm prescribing this treatment, not because you have heart disease or because you have diabetes, but because I see that there is a decrease in your intrinsic capacity, your physical and mental capacities. And then they can get, refunded and reimbursed for that. So I'm really happy that there is this kind of code, both from a clinical point of view and from research point of view.
Interesting. Okay. Now as we are heading towards the end of this episode, we do have a closing question tradition called, the hot seat, the lightning round, where we ask questions and the answer needs to be, within 30 seconds or less. So let's start with the first one, which is one test that most people aren't getting that they should be getting.
So I think this test is ferritin, the storage of iron, because it presents itself as vague symptoms and it could help from reaching a diagnosis before someone ends up shopping around at multiple healthcare physicians trying to find out what's their problem. And it's extremely common and it's easy to fix. So why not check for it?
Yeah, makes a lot of sense. Second one is, what's the most underrated longevity intervention? And also, why is it underrated?
I think one thing that fascinates me is that even a simple 10-minute walk after a meal can blunt your glucose spike. This is something that is not going to cost you any money. It's brief. So why is not everybody doing it?
Yeah, good point. Very good point. I mean, that's highly actionable. So people should really be doing it to the best extent possible. Now, on the flip side, what's the most overhyped intervention? What looks exciting, but the evidence doesn't really support it yet?
I think maybe when it comes to cold plunges, not particularly I don't buy it yet. I'm not convinced by the data yet. It seems more like a trend. It's more like, you see, I can sustain very cold temperature. Look how strong I am and resilient I am. But I'm not sure exactly how this translates into improvement at the cellular and molecular level.
But makes sense. And I also saw some like preliminary data that may even be bad for women at all. So that's also interesting.
For women, especially, it is a different level of less cold plunges, if any. Yes.
Yeah, definitely. Next one is, I think, really interesting. Like, where in medicine do you most wish we had better research? So what's the question that keeps you up at night?
I think I would like to get more research focused on women's sexual health, because a lot of women are suffering in silence and they're dismissed, and it's an important part of their quality of life. So I would really be happy and sleep better if I know that this is on the table.
Good point. Now, next one, the concept of, what's today considered fringe that you think will be mainstream in 10 years.
I think I would probably choose senolytic therapy, especially visiting.
Can you explain what that is first?
So when we think of senescence, these are cells that are not multiplying anymore, but they refuse to die. So they are zombie cells. They are stubborn cells. And they don't just stay there. They release cytokines, which can cause inflammation. And so they will damage the surrounding tissue. They can cause more inflammation, fibrosis, cancer. So I would really love to see drugs that specifically target these cells without destroying the entire immune system. And I think fisetin is one of these. It's a flavonoid. You could find it in apples and strawberries. But I think that this would probably in 10 years be mainstream therapy when it comes to health span and peak span.
I would bet big on that as well, personally, to be honest. Last one is like, if you could run any N of 1 experiment on yourself that the research doesn't yet cover, what would it be?
I would really like to explore the effects of testosterone in females and males, but maybe because I am biased and I to represent females, because they have been underrepresented for quite some time, the effect of testosterone on cognitive function. And I am particularly interested in maintaining a robust cognitive health. I believe that unless you have a robust cognitive health, then it's used as having a good body. And so this is somewhere one test that I would be keen to do.
Yeah, good. Very interesting.
You know, that one, I would be a participant for the study. If you know,
Yeah. We'll let you know. We'll let
yes.
you know. Okay, now coming to the last question of this episode, which is the return on health question that every of our guests needs to answer, which is if you could change one thing in the current healthcare system, what would it be?
I think I would make education on women's health compulsory to all healthcare professionals so that at least they have awareness when a woman in a certain age group presents to them, they don't necessarily need to treat her from or manage her from A to Z, but at least they would have the basic information to refer her to the right place, to a menopause specialist, for example, and then get the right treatment at the right time.
Roberta, thank you very much for all of your super interesting insights, ranging from clinical experience, from the research side of things. Personally, it has been an absolute pleasure having another friend here on this podcast. So, thank you very much for sharing all of your insights with hopefully many people, including potential patients, but also providers, so that we can really improve the level of care people receive and that we can make people enjoy a healthier, longer life. Thank you very much.
Thank you so much. It has been really exciting and a pleasure to be here.
Thanks a lot, Roberta. And to the listeners, go to the gym, look out for your ears, and to the woman, look out for your ovaries as well. That's it for today, and see you next time.